Доброе утро. Доброе утро, по крайней мере, в европейской части нашей планеты.
Good morning, at least it's morning time in the European part of Russia. So, welcome to our discussion on SARS-CoV-2 pandemic in Russia and worldwide. I am Sergei Scherbov, head of International Laboratory of Demography and Human Capital of Russian Academy of National Economy. And we deal with demographics in the Institute of Demography in Vienna and in Russia. COVID pandemic changed our lifestyle, changed all the aspects and affected all the aspects of our economic development. In our today's discussion, we are going to talk about the demographic sequels of the pandemic because they are really very critical. As of today, we cannot fully assess the consequences of COVID-2 pandemic, but there are still things we see already today. We see a major reduction in migration, both in Russia and worldwide, and this is understandable because of lockdowns, of borders closing, and this situation will partially be there in 2021 as well. And when the borders start opening, we do not know for how long the migrants' flows will be still reduced. Very probably this will not, the restoration of the old figures of migrant flows will not happen in the coming months. We know that some studies show that the households that were planning in January 2020 to have a child in 2020, they decided to postpone the childbirth till later on. So most probably pandemic will also influence our birth rate. Talking about the death rate, we see that the pandemic resulted in a major increase in the number of deaths, and especially I'm talking about the increase in the elderly death rate, because as we see in all the countries, among the elderly, there are more people who died of SARS-CoV-2 than in other age groups. In countries like Italy, Spain, initially they lost a lot of people due to pandemic, and assessment of human casualties due to pandemic is difficult. It's now very difficult to assess the actual number of those who died of SARS-CoV-2. Some countries have different approaches, different from the WHO standards. And then we have the same problem that traditionally happens when we are trying to assess the exact cause of death, if the patient had many comorbidities and many factors influencing the lethal outcome. And if we have a patient with a light course of COVID-2, at the same time, we know that the number of those who died of SARS-CoV-2 will be different in different statistics depending on what methodology was used for collection of these statistic data. And whichever methodology you use, you will still have a very incomplete picture of the actual number of casualties. Some deaths can be attributed just to the fact that the healthcare system is very much overloaded during the pandemic. Plus, also due to the fact that many planned interventions were postponed to post-pandemic times, and all this results in excessive death rates and excessive deaths. So we are talking about surplus death rates, which will include the SARS-CoV-2 related deaths, as well as those people who died due to the overload of the healthcare system. And in this case, it does not really matter which methodology you use to assess the number of those who died directly of the coronavirus pandemic. Now, talking about the methodology of assessment of excessive death number, let's take September 2020. We assessed the total number of people who died in September 2020. We look at the statistic figures, then we calculate the average death rate over the past 5 years in the same period, also in September, but say from 2015 to 2019. And the difference between the number of those who died in September 2015 and those who died in September 2020, this will be this differential we are looking at. But this methodology is imperfect, even though it is a popular methodology. The problem is that you can overestimate the number of excessive deaths. We understand that we are talking about big level of casualties among the elderly. We see that in Russia, in Kazakhstan and other countries, and the waves, the demographic waves, will influence the demographic casualties during the SARS-CoV-2 pandemic. And considering that Russian regions have a very different age group distribution. So if you take the average death rate to assess the number of those who died due to the pandemic, this is inaccurate as a statistic analysis tool. We did such simulations, and we saw that very often the data in mass media and other data, they seem to be excessive, overestimated. So to assess more accurately the number of those who died during the pandemic, we can look at the figures considering the age groups, and this is what we did at our laboratory. To assess the number of those who died in 2020 and compare that to the pre-pandemic death rate, we would need to model the death rate in 2020 if the patients had lived as long as they would have lived without the pandemic. And how can it be done? We make a forecast, and then we compare our forecasted death rate without the pandemic and compare it with the figures we currently have. And again, these figures, they are not very much affected by the age, and in any case, we are looking at the potential death rate. Why are we taking a 5-year span for assessment of the death rate over the past 5 years? This is important to take a period of 5 years because within these 5 years the situation may be different. That's why we need an average of the 5 years, and this way we are going to eliminate the possible error and the possible wave effect. We could take the death rate of the previous year before the pandemic of 2019, but again, there is a risk of error, stochastic error, which really happens. The death rate can go a little bit up, a little bit down. So to eliminate the statistical and stochastic error, we prefer to take an average of the 5 years of the pre-pandemic time. Or you can also make a month-by-month comparison year on year, but again, that's not very accurate. I think I have spoken enough. This is a very important topic. All the countries are now thinking of how to more accurately assess the actual death rate due to SARS-CoV-2 pandemic. And now I would like to give the floor to Simone Ghislandi, Associate Professor of the Department of Policy Analysis of Bocconi University. And he's going to talk about casualties due to SARS-CoV-2 and in historic prospects in Italian experience.
Thank you, Sergei. I would like to share the screen first of all. Can you see the screen?
Yes.
Yes. Okay. Thank you, Sergei, for the important invitation and for the important words, because actually our work is working along the lines that you just drew here in your introduction. What we are going to do here is to compare COVID-19 pandemics with the previous pandemics that we have experienced in Italy. Italy is an interesting case because COVID-19 basically hit Italy the hardest way in the first wave compared to any other country in the world, at least in Europe. And it's so we are going to talk about the first wave only. The second wave is ongoing, and new data will be released in time. Italy has experienced three major influenza pandemic waves in its history after the Second World War. One was the Asian flu, what is called the Asian flu, 57-58. Then was the Hong Kong flu. Hong Kong flu was associated to around 1 million to 4 million actually excess deaths globally. Okay. And then the H1N1 77 flu, which was a kind of lighter flu that hit the country. By far the hardest one was for us, it was the Hong Kong flu, which more or less we calculate is associated to 40,000 excess deaths in 69. So the question is COVID-19 different from these previous pandemics, and can we put it in an historical perspective? Because, you know, there are, I don't know in Russia, but certainly in Italy, there are still doubt about, oh, maybe COVID-19 is just a strong flu, okay? And there's nothing like historical data that can actually put things into perspective. So in order to do that, what we did is, and what we, if we want to work on data, the first step is to actually build the data. And what we did is to rebuild a data set of historical age, sex, province, mortality patterns. Italy has around 80, 81, 82, depending on the years, provinces. Is a country of now 60 million inhabitants, divided in 20 regions and 80 provinces. And for each at provincial level, we managed to have data about the mortality pattern. Together with the population census, which we rebuilt because the statistical office don't provide it on a digital, at least, platform, we rebuilt the mortality pattern, but also the birth patterns in such a way that so that we can actually work beyond the excess death. We can work actually up to the life expectancy and the change in life expectancy. And in fact, the outcome we want to do is to compare the excess mortality and the life expectancy of the various pandemics that Italy went through with the first wave of COVID-19 pandemic. Now, Sergei already introduced the role of excess mortality, which was calculated exactly the way Sergei was mentioning. So 5 years average before, and then compare the mortality with death. And the reason why we work on excess mortality and not on official COVID-19 mortality figures is exactly what Sergei was mentioning. So that COVID-19 casualties, at least in the first wave, were massively underestimated because the healthcare congestion brought along a lot of more case, a lot of death more, and also because the system in Italy was not efficient enough to measure really all the COVID-19 casualties with precision. But also we focus on life expectancy because life expectancy is a measure of a human cost of a pandemic for us because it allows comparison over time and place. And most importantly, you know, if the death of a person 85 years old is different in a life expectancy perspective from the death of a 5 years old child. So it kind of weights age within the human cost measure, and so that this is also what we want to capture within our analysis. So we provide the same type of figures, excess death and life expectancy, for all the three pandemics plus the COVID-19, and then we draw some conclusions. Now here, these are the type of graphs that I'm just going to work on graphs, so just to keep things more immediate. Here is the 1957-1958 pandemic, influenza pandemic. This was particularly hard in countries, probably not Italy, not as much as in Italy. Sorry, not as much in Italy as in other countries. You see that one characteristic of this pandemic, which is the same one that we find in the next pandemics, in the influenza pandemic, is that the first year is the hard one. In red, we have the darker red is the lowest is the life the loss, the highest loss in life expectancy, while green means actually the life expectancy is slightly increased. In fact. So you see that the whole country was more or less men and women more or less evenly distributed in terms of cost of loss of life expectancy. The darkest part, like Turin, this is Turin where Fiat was working, so a lot of more likely, of course, to have an influenza pandemic there at that time. We had something like less than 2 years of loss of life expectancy among the men. Men always die more of in all these pandemics than women. Okay, so this is a constant also in COVID-19. So I'm not going to insist on this because that's a taken, and there's not going to be a difference between pandemic and influenza and COVID. So this is the distribution across the country. And this is the distribution. Here are this is the different provinces that were most hit by the influenza pandemic in terms of excess mortality, and these are the age class. Okay, you see that the more or less the orange, red, or dark red are more or less evenly distributed around all class age, but we observe especially hard situation for the 5 years old children, basically for children, and for the 90 plus years old, 90 plus. So well, of course, these were not so many in that country, so it's enough to have a few more deaths to have an increase in excess mortality. But we do observe a particularly strong impact on children and on the very elderly. When, on the other hand, the Hong Kong flu hit the country, you see a much more concentrated loss in life expectancy in the north, which is the industrial part of Italy. A much bigger loss in life expectancy. We are talking about 2.5 in the most hit areas of loss of years and of loss of life expectancy. You observe a slight distribution of the pandemic also in the south, but most in the north, and mostly in the first month, really. This is November, December of 1969. Everything was caused by the pandemic, the tsunami of the influenza in 2 months in the north of Italy in 1969. So we have a loss. The big part of the big impact was in these 2 months. Overall, again, this influenza was strong on relatively, not as much as the previous one, strong on the children, but it was not as hard as the previous one on the elderly. And again, it was evenly distributed, the excess mortality across age group, especially for the 45 plus. This is, if we look at the third lighter influenza pandemic, we have more or less the same type of patterns that we have in the previous one, but with a lighter type of, with lighter excess mortality, because we don't have, here we have a loss in life expectancy that can hardly go up to above 1.5 years lost. Again, more concentration in the north, but not particularly, not as hard as before. And again, you have the children to be that are hit hard in some provinces compared to other. In fact, this pandemic, especially the 1977 pandemic, was particularly hard on children compared to other type of pandemics. But it was not as hard as to reduce the life expectancy to a very particularly high level. Then it comes to COVID-19, and it comes to this only 2 months basically. Here we are showing data from February till June of 2020. So this is the first wave only. And in the first wave only, this is Bergamo, in famous Bergamo, where I come from actually. It was the hardest hit province probably in Europe, and we actually experienced a loss of life expectancy among men above 4, around 4.2 years loss of life expectancy only for the first 6 months. So if we project this excess mortality until the end of the year, that would be associated to a loss of life expectancy of 8 years among men. Of course, this is not the case in real time, because we are experiencing a second wave, but on Bergamo it's not going to be as hard as it was the first one. But you can see here one characteristic of the COVID-19 as it was in the first wave. It was highly concentrated in some specific areas, and it hardly hit the rest. The men a little bit in this area here, which is another industrial area, but it didn't affect that much the rest of the country, but it affected very, very, very strongly the provinces where it was. This is due probably to the lockdown policies that were imposed immediately after we realized that the virus was already there in Bergamo. Because Bergamo has a characteristic. Basically, we realized that the COVID-19 was there when it was too late. So at that point, it's like we had an experiment of what is going on with COVID without lockdown. And this is this is very different from the previous graphs in terms of excess mortality. First of all, the scale. The scale here, the brown is 500% of excess mortality. Okay. Here you see the provinces that are the most hidden provinces, and you see really a brown block here, which is the COVID was concentrated in a very specific area. These are all neighbors provinces with a very specific age group, although not only the very elderly, but already above 55, above 50, sorry, we actually do observe a serious excess mortality, consistent excess mortality in these provinces. And almost nothing in the age before the critical age of 50, essentially. This is very different from the previous pandemic. So if we look at the data as they are and we compare COVID-19 with the previous pandemic, our conclusion is that the only constant thing is that the gender difference. Men die more than women. But the geographical patterns were very different. COVID-19, since it came with lockdown policies, was much more concentrated in spatial clustering. This second wave might change our conclusion because it's ongoing and we will have to update the data on that, and seems like clustering is not as strong as it was before. But that's because probably lockdown policies were not at work there. The timing also was different because the second wave of COVID-19 is showing us that while the influenza pandemic hit in 1-2 months, and then basically the years after, there was still a little bit of excess mortality, but really, really low figures. So it's in 1-2 months, everything is played by everything happens in a influenza pandemic. COVID-19 is not like that. COVID-19 is probably more like a pattern of mortality like the Spanish flu, with 2-3 waves of returning of high mortality rate.
Simone, can you please you have 1 minute left.
Yes, this is the last slide. Then we know, like Sergei said it already, we have the 65 plus, actually I would say 55 plus relative excess mortality is very concentrated for COVID-19. This was not the case in the previous influenza pandemic. And most importantly, the loss in life expectancy has nothing to do with the previous pandemics. This is more like the death toll of a war, really. Because to go back seriously to this type level of loss in life expectancy in these provinces, you have to go probably even to the Second World War and probably even before. So it is hard. The difference between COVID-19 and flu are so strong that it's really difficult to conclude that something different, that COVID-19 is not really a simple flu. That if you compare the data with our previous experience. This is I conclude, because I hope I'm in time. Yes. Okay. Thank you.
Спасибо большое, Симоне, за очень интересный доклад.
Thank you, Simone, very much for a very interesting presentation. You very clearly showed the big difference between the common influenza and the COVID-19. Because mass media sometimes say, why? What's so different between COVID-19 and the flu? It's just like a common flu. It is not. As a moderator, I have one question to you. This is what I spoke about at the very beginning. No matter how you measure the death rate, what's the difference between the COVID-19 attributed death rate and the death rate due to the pandemic, because some elected interventions were not performed and other things. And I read somewhere that some 20% of deaths some 20% higher was the death rate due to the fact that some planned interventions were canceled and people did not have all the assistance they needed. Do you have any estimates?
We do have, we did compare the excess mortality that we measure with the official COVID-19 figures, death toll in the first wave, and more or less we are around 70% more in terms of, but this is due to the fact, A, that people were dying also not of COVID because of healthcare congestion. And we don't have official figures on this yet. We are working on that, but not yet. But also to the fact that people were dying at home without a diagnosis, and without. So essentially, the sum of these two issues make the official figures are a very gross underestimation of the number of deaths really due to COVID-19. So for the second wave, we are less, because we are more prepared, of course, to measure the casualties in COVID-19. But we still are observing a difference, a slight difference. We will see in the next new data will be released this month if there is still a gap between excess mortality and official COVID-19 records. But in certain countries like Britain, for example, they had to stop even emergency oncological interventions, surgical interventions in London. In order to give space to COVID-19 patients. So you can imagine that mortality can pick up in this period, also for this externality, for this spillover effect of COVID-19. New figures will come out soon.
Okay. Спасибо большое, Simone.
Thank you very much. Thank you. It was a very interesting presentation indeed. It's a pity we have a very limited time frame for our session, so let us give the floor to Raya Muttarak. She is the program director of in Population and Just Societies program of IIASA, and Nadia Steiber, professor of sociology from University of Vienna. Are women Raya is going to talk about the Austrian experience.
Thank you, Sergei. I'm sorry I changed the title suddenly because and thank first of all the organizer and particularly Sergei for inviting me to join this very exciting forum. And I think it's also to give me the opportunity to address the gender dimension actually of the COVID-19 pandemic. Simone already mentioned and emphasized the differences in mortality risk between men and women, with men consistently have higher risk of mortality and actually of severe morbidity from influenza or from the COVID-19 as well. And actually in the case of COVID-19, so we saw the evidence already historically, but also in the case of COVID-19, the pattern is consistent across countries. But my talk is actually not going to address the mortality or morbidity part, but try to slightly unpack and work backward first. So why is this the case? Why do we observe higher mortality or morbidity in the case of men? And I sort of draw upon the two work that I work with Nadia Steiber in the case of Austria, but also the work led by Thomas Sobotka, that we try to look at the patterns of infection rates across different European countries. So I was saying that we try to work backwards slightly. Do you see my screen well? So I can just
Yes.
move the video slightly in that side. Yeah, so we try to work backwards slightly. So the fact that we observe high morbidity and mortality amongst men, is it because men are more likely to be infected than women. So I'm sort of borrowing the risk framework, because my main research is actually, I work a lot on the impact of this natural disaster or climate change on the human population. So borrowing the framework from the risk type of research. So to understand risk, we need to look at the three components of risk, right? So to have risk, first, the hazard needs to occur. So in our case, the hazard is the coronavirus, the COVID-19. But you wouldn't get sick if you're not exposed to it. So the classic example that I like to make is if earthquake happens in the remoted island somewhere, and no one lived there, then people are not exposed. So same here as a COVID-19. If you stay at home, then you don't have the exposure, so you don't have the risk. So that's one component. So in a sense, are men more likely to be infected? We also need to look at, are men more exposed to contact the disease? And also another component of risk is you might be exposed, the hazard occur, but some people, as we see in the case of COVID-19, children are not susceptible or vulnerable. So another component that we have to consider is also the degree of susceptibility and vulnerability, and that's the three components make people have higher or lower risk to COVID-19. So that's one question that we try to look at. So are men more likely to be infected than women? And if so, another thing, sort of borrowing once again from the disaster type of literature, women actually tend to be more risk averse than men, have lower risk behavior. And same thing for health behavior, actually, women tend to have smoke less, for instance, and also tend to have higher risk perception. So we also try to look at this area as well in trying to explain the gender differences. So who is at higher risk to get infected or being exposed? So as I said, you have to be exposed to the virus, but also the degree of proximity with the others also make a difference. So say if you take the public transportation or the metro, for instance, in the crowded hour, then you're much more closer to the others, so higher risk of infected. But in the non-rush hour, then it's more empty, then you're not in close proximity with the others. So the determinants of your chance of being exposed and also the physical proximity, it depends a lot on your demographic characteristics, age, as we know, children, older people, and also maybe your occupation as well. So certain occupation, you work more closely with the others, and also perhaps have higher degree of exposure as well in the constant terms can be that. And as we know, Simone has already shown geographical location make a lot of difference. Population or high density, high housing density, for instance, the rural and the urban area, the distribution, the exposure and proximity would make a difference. So are men more likely to be infected than women? Actually, they do in certain set of countries, and they don't actually, on the average, they don't in a larger set of countries. It's probably not surprising, actually, if you look at countries like Qatar, Singapore, Bahrain. So these are the countries with higher number of male migrant workers, which, as you might imagine, tend to work in the type of work that they live, the living space, they live closer together, they have high intensity of proximity in type of their work. So men are more likely to be infected in these particular set of countries. It can be really pretty much related to the nature of the work and the housing. Same as in countries like South Asian countries, for instance, like Pakistan, India, and certain sub-Saharan African countries, men are also more likely to be infected, which you may think because men also, the female labor force participation is much lower, or women tend to stay home more in the case of India, Nepal, and Pakistan, so they're less exposed. But then in the largest set of countries, particularly the European countries, you observe more the gender balance in terms of confirmed cases. And actually, in many cases, it's more women, in fact, more likely to be infected. Now, what I'm showing you here, it's one thing that I'm missing completely from this picture is not adjusting by age patterns. Sergei already mentioned clearly in the introduction to this session that age is a strong, also another important demographic component that we have to take into account. Since we know that severity, hospitalization, mortality, and fertility risk vary strongly, not only by gender, we see men die more, but also by age. So not taking into account the age component, we probably would miss the picture of trying to understand are men more likely to be infected or not. And of course, we also should account for the age and sex composition in the population and the age and sex pattern of the infection rate. So most of the existing number or the data or studies that we see tend not to combine these two components together, age and sex patterns in infection rates. One of the reasons, I guess, it's the data is there, but it's a bit harder to dig into, and many countries do not publish. In terms of mortality case or even excess mortality, you can tell the age sex difference, but not so much on the confirmed cases of infection. So we try to collect intensively, go back to the report of each country that we manage to have access to, and try to collect the data by age and by sex in terms of breaking down the confirmed cases by age and by sex. We managed to collect for 7 European countries. And another nation that I think it's very important, as Simone also mentioned, it's the timing, right? So the first wave, and now we're in the second wave, likely to be prolonged for another months and maybe year even. So the nature of the development of infection, of course, mortality, we should also take into account the monthly development, because it also matters in terms of the testing policies. Testing policies also make a difference in terms of how do you detect the infection as well. So we try to, up until mid-November, that we have the data for these 7 countries. We look at the different countries, put the age group in a different way, but we try to aggregate at least to look at the difference by 10 years age group. And these are the countries that we have. So we also, I think it's quite nice to try to have a bit of different representation of a set of countries in Europe. England is considered to be in Europe as a sense of not EU, but Europe. We have England data as well, and in some Southern European countries, Italy and Spain, and also the Czech Republic. But what I like to highlight it's a bit here on this male to female ratio. So if you look at the infection rate per 1,000 population and just make the ratio between men and women, so in all of these 7 countries, the same pattern. So women on the average, so not adjusting for age, would be women have higher proportion of confirmed cases. And now I'm gonna try to break down into the age differences. So I guess the easiest way to look at the male to female differences and then try to also adjust it for not only by age, but also maybe different countries have different testing policies, different way of collecting the data. So the easiest way is to look at infections per 1,000 population and then just do the ratio between men and women. And this interesting pattern would emerge. So we have age on the x-axis and the infection rate on the y-axis. But if we look at the ratio, what is interesting here is, so here it's 1, right? So 1 would be men and women have the equal chance of being infected. But when it's lower than 1, then it's higher in women. And then when it's higher than 1, then the infection rate is higher in men. This is just to show you in the case of the Netherlands, but to show that the overall cases, I think this is what is interesting. The red area represents the average across the 7 countries. So up until the age of 60, women have higher infection rates than men on the average across the 7 countries. But then after the age of 60, men have higher infection rates. And we started suspecting, so it probably has to do with the nature of labor force participation, because for certain reasons, up until 60, which is the prime working age pretty much, both for men and women, we observe high infection rate for women. And then the crossover, it's quite clear cut. If you think about retirement age, for instance, then after 60, then we see men have higher infection rates, because possibly or likely to be, as we know, that men also have tend to have more severe symptoms from COVID-19 and higher likelihood of mortality. And if our suspicion is likely to be correct, if you can see in the labor force participation, for example, if you look at Italy or Spain, the crossover between men and women happens likely before the age of 60, because if you know the labor force participation, women in this country also withdraw from the labor force slightly earlier than the age of 60, as compared to, say, the Netherlands or Switzerland. But on the average, it must have something to do with the work. So now the next question would be, okay, so if this is the case, because men also work too, right, in this age group, not only women, and probably even more in general, then does it have anything to do with the nature of work that women are more likely to be engaged with? As we heard all the time, that healthcare workers have higher risk of exposure to COVID-19 infection. Oh, 2 minutes. Yes. Yeah. So as we know, so they have higher exposure. Women tend to be more concentrated in this type of job, same as work in the elementary occupation, tend to have more women as well. In fact, indeed, this is just the UK data, women tend to be highly concentrated in the healthcare related or elementary occupation, which also have higher exposure. So that's probably one of the reasons they explain. So now the work that I've done with Nadia Steiber, it's also to look at, okay, so if we can measure, do people tend to get infected in the workplace? Then we don't have such a data directly that we can measure where the infection takes place. But we can measure through the survey that she has done back in June in Austria, is to look at the perceived occupational hazard. How do people perceive their risk? This is a question actually of how high do you estimate the risk that you will get infected with coronavirus in the workplace? They can rank from very high, rather low, and very low. So in the rough descriptive analysis, not controlling for anything, women have slightly higher perception that they would get infected in the workplace than men. But once we, and of course it's vary by sector, if you work in a sort of healthcare, retail, tourism sector, then you perceive higher risk. Women, as we said, tend to be represented in this sector. So the gender difference that we observe earlier, so instead of controlling for working hours, for firm size, women tend to have higher perception. But once we adjust or we account for the type of economic activities actually that women tend to engage with, and also the proportion of female in the workplace, this gender difference in the perception disappears. It doesn't matter if you're a male or female respondent, but it's actually what matters here is the sector of activities. And also if the workplace, the job tend to be female concentrated, because you think, okay, we have the same sector, maybe health sector, but women might tend to be engaged in a more low elementary type of job that engage more with people, for instance, then they also have higher chance. So I think I have to wrap up, this is what I want to wrap up. So the gender difference that we try to explain, in this case, particularly focusing not on the sex and biological difference, but in the type of the socially related to the type of activities that men or women are engaged. So in this sense, the type of industry, the type of work women engage, make a difference in male or female vulnerability to infection. That's one thing. And I think this is my last slide. So just to say that to understand not only gender differences, but different in between different sub-demographic groups, one important is to really consider the combination of the characteristic, not only men, not only women, but maybe because they're more or less likely to be exposed due to their occupation or their age as well, and the interaction between different characteristics. So I would ask the policymakers, the government, to provide us with the data which are disaggregated as much as you can by age, by sex, by gender, by socioeconomic characteristics, and that would help us to understand better the nature of the pandemic. Thank you. I'm going to stop here.
Thank you very much, Raya, for a very interesting presentation, which really showed to us the difference in mortality and morbidity between men and women, first of all. And we have questions. We have questions from the audience. Or we do not have them. I'm trying to find it out. Okay, I have a question. We don't have much time to go, but I have a question. Now, based on what you told us, do you see any difference between the first wave and the second wave in these statistics? Or the findings you were talking about were common for the first wave and the second wave?
Yes, actually, I didn't have a chance to show, but it does make a lot of difference, especially if you think of to be able to know who get infected is actually, it depends a lot on who get tested. And in the first wave, the testing policies differs compared to the summertime, which the government tried to test everyone. Then the gender balance in the summertime, it's not as distinct. Then we started picking up again because the testing also changed in the second wave when the disease get much more serious and in summer. So again, of course, if you get sick, which tend to be older people, and then men get sick, more severely sick more, then we start seeing again this age sex difference in the second wave. It's really, I think the timing, month by month, make a lot of difference in picking up these, I would say, both age and gender differences.
Спасибо большое. Я думаю, что...
Thank you very much. Thank you. It is a pity we have very limited time, so I think it's time for us to say a few final words. We had a very interesting set of presentations in this discussion panel, and I think that this year we will have much more data on what really happened, because as of today we lack accurate data on the full mortality rate, on the birth rate. We do not have full data on who has had COVID-19 really, who has not, on who was diagnosed and how. This year, we are sure to have really big data on COVID-19, and these data will be unique, and I'm sure the conclusions we will make based on these data we expect so much will also be unique and very interesting, unexpected maybe. We will be able to analyze both the actual sequels of COVID and analyze the factors that would probably help patients to prevent these consequences. So I would like to thank our speakers, Raya and Simone. Thank you very much for your presentations. We enjoyed them so much. I would like to thank our audience who was listening to us. And of course, I would like to thank the organizers of the GAIDAR Forum for having invited all of us to participate in this interesting demographic discussion about the sequels of COVID-19 pandemic. Thank you.